out and extends to the side wall of the pelvis. This is where the sciatic nerve transits from the spine to the leg. And so patients will present with a shock type pain extending down the leg. Only about 6% of patients have this, but if they present with pain, then they usually have advanced stage disease where the likelihood of our curing her cancer is very low. If cancer of the cervix begins to spread, and this is true both for squamous cancers and for the glandular cancers, it usually will proceed into the lymphatic system. Most commonly, the spread is to the obturator nodes at the side of the pelvis. But there is a lot of new information in the last few years using sentinel node mapping technology that shows that occasionally, when spread occurs, it can bypass the pelvis and move straight to the common iliac or para-aortic nodes. This is relatively new information, and it will begin to change how we treat our patients surgically for cervical cancer. We now do a routine para-aortic node dissection when we treat surgically in order not to miss early spread at those sites. I believe yesterday there was a discussion of cervical cancer staging. I won't review it at length in order to not be repetitive, but I'll just show you a few of the key points that are important. In general, we use the FIGO system. That's the International Federation of Gynecology and Obstetrics for staging. It's an international staging system used around the world. The staging system attempts to divide the extent of disease into prognostic groups. So microinvasive disease, the stage 1A lesions, are lesions where we have a very high likelihood of curing the patient, and that we can probably do so while preserving her fertility. So it's very important for us to recognize what the characteristics are of microinvasion. You heard this morning, before my first talk, the description of microinvasion being less than 3 millimeters deep, less than 7 millimeters wide. That patient, if she has squamous cancer, has almost no risk of spread into the glands. And this would be the lymph glands. However, if she has an adenocarcinoma of the cervix, less is known about this, and I'll talk about that in more detail in a moment. The bulkier lesions of the cervix are the stage 1Bs, and these are stratified. What becomes important here is that the chance of that cancer spreading into lymph nodes is much higher. Depending on the actual diameter of the tumor, it could be 30 or 40%. And because of that, our management plan for treating that patient will be substantially different. Once the nodes become involved, surgery by itself is not curative. And so we would often include radiation with chemotherapy to treat that patient. Once spread is outside of the cervix, we would see stage